मी आहे ना मीटिंग सुरू झाली ड्रेस बदलून आले. तुला काही दिसत सर्व बाहेर येतो.
Yes, Rakesh.
Yes, sir. Sir, just a second, sir. Actually, it is in buffering. So we are just within a second will be go on live.
Capture पाच बसलं पाच.
Yes, respective faculties, we are on live on YouTube. So, Madan sir, shall I go ahead?
Yes, yes.
So good evening, respective faculties. My name is Rakesh Kumar on the behalf of Corona Remedies Limited. So it's my privilege to introduce our esteemed conveners for today's webinar. So we're honored to have Dr. Madan Kambleshwar, who is a National Coordinator, Oxy, Sexual Health and STA Committee, and also serves as the General Coordinator, Amogs. And also we have Dr. Rachna Raju ma'am, who is representing CP Safe Motherhood and Quality Care Committee, Amogs. And followed by, we also have Dr. Prerna Keshan ma'am. She is also a National Coordinator, Foxy, YTP Committee. So we're truly privileged to have such experienced and respected leaders guiding today's session. So now, sir, I am handing over the sessions to you. So I'm here to help you out if anything is required, sir. So over to you, Madan Kamleshwar.
Thank you, Rakesh. Can I have next slide?
Yes, sir.
Yes. Good evening, everyone. I request and invite all the dignitaries join for today's webinar for the lamp lighting. Yes.
Actually, on the
Rakesh.
next slide, actually, we have, sir, the prayers.
It's okay. Now play the video of this lamp lighting. Yes. Good evening, everyone. It's my privilege and honor to invite you, welcome you for this webinar, which is the fifth episode of Surakshit Matrutva Vyakhyanmala. It is the brainchild of Amey sir, respected President Amogs, and on behalf of this Amogs and the Committee of Safe Mother and Quality Care of Amogs, which is headed by Dr. Rachna. And with due respect to Amogs office bearers, respected Amey Purandare sir, President Amogs, and Dr. Rohan Palshetkar, Honorary Secretary Amogs, I welcome you on this online platform. We have covered rest of the zones of Maharashtra. Now, in this episode, we have covered the zone 2 and zone 3. Almost 10 to 12 societies are there, and I'm very much thankful to all the presidents and secretaries for accepting our invitation and joining with the committee and the Amogs and their sincere participation. We are so honored to have the chief guest for this webinar, Dr. Amey Purandare sir, President Amogs, and respected Dr. Asha Dalal madam, who is the trustee of Amogs, and also the esteemed guest of honors, Dr. Suvarna Khadilkar madam, Secretary General Foxy, Dr. Madhuri Patel madam, President-elect Foxy, Dr. Kiran Kurtkoti sir, immediate past President Amogs, and Dr. Varsha Baste ma'am, past Vice President Foxy. And along with the cooperation of zonal coordinators, Dr. Kundan Ingle, who is the zonal coordinator of Zone 2, and Dr. Varsha Lahade madam, who is the zonal coordinator of Zone 3. and along with my conveners, Dr. Rachna and Dr. Prerna. And also, we have got the esteemed speakers for today's session. There are two talks, fantastic talks, and one panel, as usual, pro forma for this Mala. We have got Dr. Uma Wankhede Madam, President of Pune OBGY Society, and Dr. Gauri Karandikar Madam, who is the past President of Nasik Society, and esteemed chairpersons and even moderators, Dr. Nalini Bagul Madam and Dr. Manisha Jagtap, and expert is Dr. Narendra Zope, and all the esteemed panelists. We are so much grateful to for this particular series, and Amir sir has allowed us and given the opportunity to conduct this Surakshit Matrutva Mala on for the celebration of Safe Motherhood Day, and we are covering almost all the societies of Amogs. Only zone 4 is remaining, which will be covered after 10 to 12 days. I welcome all the dignitaries for this webinar. And may I request Rakesh to have the CV of Dr. Amir Purandare sir. I welcome Dr. Amir Purandare sir for your word of wisdom and your blessings, sir. Over to you, sir.
Yeah. Madan, can you hear me now?
Yes, sir. Clear.
Okay. It gives me great pleasure to be here this
Rakesh, please mute others.
It gives me great pleasure to be here this evening as chief guest for this Surakshit Matrutva Vyakhyan Mala. Really good effort by the conveners, Dr. Madan Kamble, Dr. Rachna Jaju, and Dr. Prerna Keshan. I bring you greetings from Amogs. I'm very happy that myself and Dr. Rohan Palshetkar, Secretary Amogs, are extremely pleased with the passionate efforts and the determined efforts across Maharashtra that all Amoxians are showing in our Mission Me, Mission Sri campaign in order to ensure that we carry out the nischayas, that the pledges that we took during the conference at Mumbai of Sri Shakti, Sri Suraksha, Sri Shiksha, Sri Swasthya, Sri Sukh, and Sri Samruddhi. So I am hopeful that with all these efforts that we put in, we will certainly able to fulfill our theme for the 2 years, that is Arogya Sriche, Samarthya Rashtrache. We have launched various campaigns in the last 1 month, ensuring fitness, talking about the myths and the realities about infertility, and also vaccinating the ladies between 16 to 26 years of age free of charge. But I think what is most important and what is acknowledgeable of Maharashtra is our fight against maternal mortality, as we are one of the leading states to achieve or to closely reach the goals of not only reducing but close to eliminating maternal mortality. And that is why this particular Vyakhyan Mala was conceptualized. I'm indeed happy to be in the presence of our esteemed trustee, Dr. Asha Dalal, my mentor, then Dr. Madhuri Patel, President-elect of FOXY, who has always encouraged all Amoxians, Dr. Suvarna Khadilkar, who is a part of the Amox family, and Dr. Kiran Kurtakoti, my good friend and immediate past president, whose visionary thoughts led to the creation and functioning of the Maharashtra College of OBGYN. Special mention to past president of FOXY, Dr. Varsha Basse, who has always encouraged me right from my childhood to do good things for Amogs and to give all my time and effort towards the improvement of Amogs.
You are the best.
Thank you, madam. Also, I'm very happy that today's scientific program has got faculty of the highest quality and talking about extremely important topics like cord prolapse by Dr. Uma Wankhede, cesarean section infections, preventing postpartum morbidity by Dr. Gauri Karandikar, and a very important panel discussion on ectopic pregnancy clinical scenarios by Dr. Nalini Bagul and Dr. Manisha Jagtap. Uh, I'm sure that the entire scientific program has got an inclusive uh, representation of Zone 2 and Zone 3 faculties. Zone 2 and Zone 3 are important zones of Amogs. For me personally, Pune and Nagar are my roots. So, Loni, Baramati, Satara, I have traveled personally there, and also Nashik, Dhule, Jalgaon, Malegaon, Charisgaon, and Buldana. Um, I have got from my father's side very close links with Nashik and Jalgaon. So I'm indeed very happy. I hope the delegates will listen carefully to these pearls of wisdom that these eminent faculty are going to enlighten us with this evening. And I'm very happy and sure that these delegates who are attending, not just from Maharashtra, but even beyond, will definitely benefit. Last word of special encouragement, appreciation, and acknowledgement to Madan Kamble, to Rachna and Prerna. Madan and Prerna are indeed very hardworking people. I have worked with them in Amogs closely, and I wish them well for their national Foxy endeavors. Rachna, you are doing a fantastic work with the Safe Motherhood Committee. I already told you I am extremely proud of your efforts. And please keep on this momentum going, and we will take it even further. With these words, once again, please let us learn together and let us ensure that we are able to accomplish our mission me, mission 3 and uplift the health of the women of Maharashtra. Thank you once again. Jai Hind, Jai Maharashtra, Jai Amogs.
Thank you, Ame sir, for your constant guidance and encouragement, which helps us always progressing in Amogs and taking the Amogs to certain height. Thank you so much for being with us, always supportive. I request Dr. Rohan as Honorary Secretary to have his address, please. Over to you, Dr. Rohan.
Thank you so much, Dr. Madan. I hope I'm audible.
Yes, yes.
All I want to say is that I think it's a fantastic thing that you're being so collaborative amongst all the societies, ensuring we all get together and are carrying out programs in order to update ourselves regarding safe motherhood. Because I think that's something which is priority in today's era, not only for our patients but for our doctors as well, to ensure when is the right time to refer, when is the right time to take action, and when is the right time to actually help out each other in certain emergencies. So I think that's a fantastic program that you've been carrying out for so many days, and as you said, we're looking forward to the Zone 4 webinar as well, and it's something looking forward to. There are immense doyens you've called onto the dais today. Amay sir, who's always been there, my mentor through Mumbai Society, through Amogs, and through Foxy as well. He's been guiding me for the last 10 years, and I hope I'm doing justice to my post in Amogs this year for him. Dr. Asha Dalal ma'am, who has shown great faith in me and has also been a guiding light through my Amogs journey. We've got Dr. Madhuri Patel, ma'am, who's the president-elect of Foxy. She's been someone who's always been a rock, a simple phone call away, and she's always there. Dr. Suvarna Khadilkar, our Secretary General of Foxy, she is carrying out duties way beyond what is required for Foxy, and she goes out of her way, being there always, and she's an inspiration to all of us. Dr. Kiran Kurtakoti, sir, what can I say? He's been someone who's always given a free hand. Like whenever you call him, he'll be like, "Ha, Rohan, bol. Ha, ठीक है, तू कर ना, मला नंतर सांग." So that is the something that is truly something to learn from him. That being inclusive and giving a chance. And Varsha Baste, ma'am, what can I say? She's been more like a family more than anything else. Seen me grow up as a young child to doing all the work towards the societies. Thank you for always being encouraging, madam. And you've
You are
always
doing
been a
well.
pillar of strength.
Yeah.
Thank you,
All the
madam.
best wishes to you, Rohan.
Thank
I
you so
want to
much.
see you as a Foxy president also.
Thank you, madam. Thank you. And we've got our zonal coordinators, Dr. Kundan Ingre and Dr. Varsha Lahade, ma'am. Kundan sir and Varsha, ma'am, what can I say? They've always I one thing I love about Amogs is they're always just a phone call away. You pick up the phone, they'll be there for you no matter what the most amazing part is you picked up, as Amay sir said, the doyens in the field for these specific topics, and they're important topics. We always read them in the textbooks, but it's necessary to update ourselves with the recent advancements. And I think these are fantastic topics that you've picked up. So I wish you all the best for this webinar. And Dr. Madan Kamble, I wish you all the best for your future endeavors in Foxy. Dr. Rajna Jaju, ma'am, you've been doing superb work in Amogs. I think it's wonderful, and it's a real pleasure to be working with you. And Prerna, I can say now, our honorary Amogsian, as Amay sir has said, all the best for your this. And I love the work that you're doing in the YTP committee. I think you're a fantastic leader, guiding all our young members and showing them the ropes and as we go ahead. So all the best for this webinar, and I really look forward to hearing all the faculty.
Yes, thank you, Dr. Rohan, for always you are encouraging and supporting all the youngsters and all the active members of the Amogs. Thank you so much. We have our chief guest, Dr. Asha Dalal, ma'am. Ma'am is past president of Amogs and also trustee of Amogs. And we welcome Asha, ma'am. Ma'am is currently busy. She may join after some time. We will welcome whenever she joins. I hand over to Dr. Prerna for further proceedings. Thank you so much.
We have the Asha madam with us.
No, ma'am will join later.
Streaming into this very, very wonderful evening, heartfelt gratitude to every dignitary who has joined in. And it gives me a round of pleasure to introduce our guest of honors for today. Our very first guest of honor is very revered Dr. Suvarna Khadilkar, Madam, Secretary General Foxy. What to say about Madam? I have this distinct privilege to introduce a leader of Foxy whose vision and dedication has continued to shape our collective journey in Foxy. Ma'am, being the Secretary General with the deepest commitment, valuing mission and inclusive growth, instrumental with so much clarity and compassion. Ma'am, we are here to have your words of wisdom.
At the outset, I want to thank Amogs, Ameya, Rohan, and the entire team for inviting me here as guest of honor. I can see Dr. Asha Dalal joined in. She's always there to bless everyone in Amogs. She's a patron, she's a past president, and I think her guiding light is always there for the Amogs society as such. And I can see so many stalwarts who have joined: Dr. Kiran, Dr. Madhuri, Dr. Varsha, and our dear Prerna and Madan, who have been working very hard since long time. So I congratulate all of you. I think, and Dr. Rachna is also doing this webinar. So congratulations to all three of you for doing wonderful coordination with all the members and all the societies who have joined. The Pune society, I think I don't much understand, but Zone 2 and Zone 3 societies, if I am not wrong, are the participating societies, and there are so many member bodies in that. I think the Pune, Ahilyanagar, Loni, Baramati, Satara, Nashik, Dhule, Jalgaon, Malegaon, चालीसगाव आणि बुलढाणा. थोडंसं मला मराठी सुद्धा बोलायला आवडेल, कारण आत्ताच एक महाराष्ट्र दिन होऊन गेला आणि एक मी सुंदर त्याच्यावरची एमॉग्सनी केलेली क्लिप पाहिली. And it was a very well made by, I think, Revati Rani and under guidance of Amaya and Rohan. So I think overall Amogs is doing wonderful work and having safe motherhood lecture series or Surakshit Matrutva Vyakhan Mala in itself, it speaks about how much we are, how much ever we do, less it is to save every life of mother. And I always feel that we are, chasing a target of SDG goals. We have always, long time ago, we have already surpassed that target. And when there is a target of, say, 70 or whatever, I always feel that why do we have this target of 70? Why we can't say that let us all have a zero preventable maternal death. Our target should be zero preventable maternal deaths. And I think that is what we should, each one of us should try. And I'm sure everybody together, collectively, will have our mission successful. And all the efforts which are going on, I think all of you have seen what government statistics, the maternal mortality statistics that we see over the last years. We have tremendously gone from 3 figure to 2 figure in short period of time. And ours is the only country where, this such a great reduction has happened. If you see America, if you see other countries, the maternal mortality has not been that significantly low, even though it has been on a decreasing trend. I think India has done wonderful work, and even WHO has kind of appreciated India's work. And it is all collective efforts of government of India, government of Maharashtra, and all the NGOs who have common goal in mind, and that is safe motherhood. I wish you all the best for your seminar. I see all the stalwarts and great speakers for your very nicely selected topics they are going to take. And thank you very much for having me here as guest of all. Thank you.
Thank you. Thank you so much, ma'am. Definitely with a vision of zero death for maternal mortality and enlightening words that you have, we are really, really blessed to have you amongst us. Ma'am, we also seek your revered blessings for all our future endeavors. Thank you so much, ma'am, for being with us.
Thank you.
We now introduce our next guest of honor.
Prerna, Asha Dalal ma'am is there. We can have blessings of Asha ma'am. Yeah, Asha ma'am, please.
Good evening, Madan.
Good
Thank you
evening.
for inviting me. You know that y'all are the future of Amogs. I'm so glad that you have chosen this very basic topic. And it's so nice to see so many of y'all getting together. I'm sure you're going to do better and better. I wish you all the very best. There are lots of it. You've chosen wonderfully interesting topics. So I'm not going to waste more of your time. I wish you all the very best. And I hope you have many such more programs in the future.
Thank you, ma'am.
Thank you so much for your kind blessing, ma'am. Thank you so much for being with us in your busy schedule. Thank you. Yeah. Over to you, Prerna.
We now move on to our next guest of honor. What to say about Madhuri, ma'am? We have Dr. Madhuri Patel, madam, President-elect Foxy. Such a privilege to invite madam, a leader chosen by all of Foxy, fellow Foxians, to guide us into the next chapter. Ma'am, with her years of service, track recording innumerable achievements of highest realm, and a vision encountered with unity and progression for the organization. We welcome you, ma'am, for all your words of wisdom.
Yeah. Thank you, Prerna, for your very, very kind and warm words. I would like to say that Dr. Amaya and Rohan are my student. And, I must add that Rohan is my best friend's, son. So both of them are like my son. And, I'm today seeing them progressing as a president Amogs and the secretary Amogs. So I'm very proud of both of you. And of course, Dr. Asha Dalal, we have worked together but in a different institute, and we are very good friends. Suvarna, again my buddy, and all we are working together. So I'm very happy in amongst this initiative has taken place, Surikshit Matritya Abhiman, which is very important. In 2018, I was at the government office with the meeting, and that time, the Dr. Deshpande, director from Maharashtra, he presented the MMR in Maharashtra. And 2018, the Maharashtra MMR was almost 33 per 100,000 live birth, which was very, 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 improved, what you say, figures. And he explained three factors why we could reduce the Maharashtra MMR. So, at 33 per 100,000 live birth. So, three factors were playing important role, and now also they are playing that more than 99% of the institutional deliveries are happening, and they could improve the manpower in form of obstetrician and the midwifery. And thirdly, they could improve the infrastructure. So that is Maharashtra is definitely example for all the states of India, and I'm very happy that Maharashtra should come with all this abhiyan. They should get by 2030 single digit, because we have already achieved the goal of 2030. So we should now come to the single digit by 2030. So that is our goal. And secondly, I must appreciate everybody, Prerna, Madan, all the entire, Amogs, community office bearer. They are doing excellent work, and I wish them all the best without wasting much time. So thank you once again for inviting me for this webinar.
Thank you, madam, for your esteemed blessings and your enlightening words. And ma'am is one of the most grounded and loved leaders Foxy has ever decorated. Thank you so much, ma'am, for being with us. I now hand over Dr. Rachna.
Yeah, ma'am. Good evening, everyone. It is my honor and privilege to be associated with this webinar of Surakshit Matrutva Vyakhyan Mala. And we are blessed that... Can everyone be muted? We are blessed to have blessings from all the stalwarts from the field of OBGY. And it is my great honor and privilege to introduce our guest of honor, Dr. Kiran Kurtakoti, sir. For sir, I would like to say, great leaders don't set out to be a leader. They set out to make a difference. It is never about the role, but it is always about the goal. So this goes correct with Kiran, sir. He is immediate past president of Amogs, and he has taken Amogs to newer heights. And it is my immense pleasure to introduce such a grounded human being. Over to you, sir. Kiran, sir?
Yeah. Sorry.
Yeah.
Sorry.
No problem.
Well, respected Dr. Amaya Purandare, sir, Dr. Asha Dalal, madam, and of course the guests of honors, Dr. Suvarna. Is it okay? Has Varsha spoken?
No, sir.
Not yet.
No. I
Not
mean,
yet.
we will respect the seniority, and I will
No,
pay
no, no,
Dr.
no,
Varsha
no, no.
Bhatte.
Kiran, Amogs है. I
अरे
want
नाही
you to.
वर्षा, तू अमॉक्सचीच आहेस. You are senior to me, and as a matter of
Now you
respect,
continue. Now.
we always respect our seniors. So as a matter of request, I would request Madan ji and Rachna ji to allow Varsha to speak first, please.
Yes, madam, please.
I am sitting here. I am not going anywhere.
Yes, over to you, ma'am.
Good evening, everybody, and I am so happy to be here. बऱ्याच दिवसांनी आलं तसं लोणचं खाल्ल्यासारखं वाटतंय मला. I am so happy to be here attending this webinar on Surakshit Matrutva Vyakhyanmala. What should I say about Amogs? Amogs is the heart of Foxy. It's a big-hearted society, so many OBGYN societies. This is like the biggest, organization of Foxy into Foxy with so many OBGYN societies. And what should I say about Ameya and Rohan? They are really झंडा एकदम जोरात एकदम त्यांनी फडकवला आहे. Both of them are so aggressive, knowledgeable, and really true leader to work for Amogs, and they are doing wonderful work through Amogs. Really happy to be here, Dr. Madan. You have organized this wonderful webinar on Surakshit Matrutva Vyakhyanmala. I should bow in front of Dr. Asha Dalal Madam, Suvarna Khadilkar, Dr. Patel Madam, Madhuri Patel Madam, also our friend Dr. Kiran Kutarkoti, and all you present here, the zonal coordinators, Dr. Kundal Ingle, Varsha Lahade, and the conveners, my great friends, Dr. Madan Kamble, Rachana, and beautiful Prerna from Far East, India. And the speakers are also really good. Our own NOGS past president, Dr. Gauri Karandikar. She's such a wonderful and intelligent lady. You have chosen
really good people, Dr. Madan. Dr. Uma Wankhede also, I'm looking forward to hear her. And the moderator for the panel discussion on ectopic pregnancy, Nalini Bagul, and all of them. Our now president, Dr. Manisha Jagtap, is a co-moderator. So, and I know Dr. Zopels, who is the expert, and all the panelists from this Charlesgaon. I belong to Charlesgaon, Pune, Ahmednagar, Loni, Baramati, Satara, sorry, Nashik, Dhule, Jalgaon, Malegaon, Charlesgaon, Buldana. So many societies and their president, secretaries are there as panelists and chairpersons, and it's a wonderful amalgamation of knowledge and people coming together. And the topics also are very well selected by Madan and all the conveners, and cord prolapse and infections in cesarean section, preventing the postpartum morbidity. I'm really glad, and I shouldn't talk too much. Already I have already spoken a lot. Dr. Kitarkoti, the stage is all yours, and you take over now. Thank you for giving me this such respect, and I love your gesture also. Thank you. Over to you, and I really wish all the best to Madan, Rachana, and Prerna Keshan. They are really wonderfully doing everything, and they are true leaders. I have seen them working from so long, and I wish you all the best. Over to you.
Thank you so much, ma'am. Thank you. Yes, sir. Kiran sir, please.
Yeah, so on behalf of Amogs, actually it's an Amogs webinar. So on behalf of Amogs, welcome to all of you, respected Amir sir and Dr. Asha Dalal madam, and of course the guests of honors, Suvarna, Madhuri and Varsha, and zonal coordinators Kundan, Varsha Rahade, and of course the conveners. I mean, what can I say about Madan? What can I say about Dr. Rachna? Fantastic conveners. Madan, this must be about your 1000th webinar, I think. And for the last two years in my presidency, practically every Monday and Thursday, you have made me sit in front of the PC to greet everyone. And I think the same zeal continues. It requires a lot of efforts, Madan. So best wishes to you. I think you should be unopposed in this particular election of yours. And Rachna, we also would like to see you at the national forum also. Prerna, thank you, Assam, for painting Assam saffron, and thank you. I mean, we have already included you as honorary member of Amogs, so best wishes to you also. And I take this opportunity on with my president of Pune, Dr. Uma Wankhede, my teacher, to invite all of you for the Amogs zonal conference, which we are going to have on 31st October and 1st of November. I see all of you, all those who have joined, those who wish to be a part of this conference, please give your names to either myself or to Dr. Uma Wankhede, our teacher, or anybody or to Dr. Kundan also, or Dr. Chaitanya and Dr. Charu Bape. Anybody you can give your names. So most welcome. And I really want to speak because all my friends are there. Uma is there, Dr. Gauri Karandikar is there, Lalini is there, and everyone will be talking on fantastic topics on safe motherhood. And for the information of everyone, the mat mortality of Maharashtra at least has come down to 33, and I am sure that under the able guidance of Dr. Ameya Purandare, we will be able to reduce it to the single digit numbers. And my best wishes to all of you and all of us also in this endeavor. So without much ado, I would request Madan, Rachna, and of course Prerna to get on with the webinar. And I'm really keen to listen to my teacher, Dr. Uma Wankhede, who has taught me cord prolapse in my third MBBS as well as at my PG days, and I would like to return to those memories again. So, without much ado, please get on with the webinar. Thank you so much.
Thank you so much, sir, for those kind words. And we also want to welcome our zonal and Dr. Varsha Lahani, madam. We would like to have a word from you. Sorry. Madan sir, over to you then.
No, no. Varsha madam is not joined.
Yeah.
No.
Well, then you should start the webinar now. It is already 6:30.
Yes, yes.
6:40.
Are you continuing, Rachna? Yes, sir. We are starting. Thank you once again, all the chief guests and dignitaries who have joined and blessed us for this webinar. Thank you once again, all. Yeah, we will start the scientific session. Rachna?
Yeah. Moving towards the scientific session, the first session for today is we have speaker Dr. Uma Wankhede madam, and
Yes.
it is a great honor to learn from the learned. So for this topic, we have chairpersons Dr. Renuka Pathak madam. She's president of the Ahmednagar Society. Dr. Sanjay Jadhav sir, he is president Satara OBGYN Society. Dr. Kundan Ingre sir, who is zonal coordinator for Zone 2, and Dr. Vaishali Chaudhary madam, who is president of Jalgaon OBGYN Society. I would like to request chairpersons to please introduce our speaker. Renuka Pathak madam, please unmute yourself. Yeah.
I'm indeed happy that you've invited all the presidents and secretaries from all the different societies, and with all the dignitaries in presence of all the dignitaries, I would like to start the session. And I'm really very happy to introduce Dr. Uma Wankhede madam, who's been my teacher, and we've seen her throughout my journey from as undergraduate, postgraduate, and it's a real pleasure to see her as the president of Pune Obstetric Society for the year 26-27. She's an ex-professor at HOD GMC Baramati, Fogarty Fellowship from Johns Hopkins University, USA, and she's published more than 50 scientific papers and chapters in several textbooks. And Dr. Uma Wankhede madam is a hardcore teacher, and we are really looking forward to the common topic as cord prolapse, but still there will be something new that she'll add to it. And I think for everyone needs to brush up, because finally, whenever it occurs, it really is a nightmare for anyone or any obstetrician. So looking forward to wise words from Dr. Uma Wankhede madam.
Hello.
Rakesh, please stop share.
Yeah.
Rakesh.
Madan, can you hear me?
Yes, madam. Yes.
Yeah,
Rachna,
thank you very much.
Yeah,
Yes.
I'm sharing. I'm sharing.
I thank Dr. Amay Purandre and Dr. Rohan Palchetkar for giving me this opportunity. I thank Dr. Kiran Purtukoti, as usually always praises me. I thank Dr. Madan, Dr. Rachna, and Dr. Prerna. They are so kind. Actually, my laptop just collapsed 10 minutes back, but somehow they are getting it through to me. I thank the Dr. Renuka. I remember our days in Sassoon. I don't know, Vaishali Chaudhary. I just love the time I had in Jalgaon with her. And of course, Dr. Kundan and Dr. Jadhav. So I'll start the presentation. Actually, cord flaps, one will think, what there to talk in that? There's only one treatment, that is the immediate cesarean section. But maybe there are some more things to it than only cesarean section. So let's go into it and see some more details of cord prolapse. Next. Rachna, can you please change my slide?
Yeah, ma'am. I'm changing. Yeah.
So we all know that cord prolapse is a very important cause of fresh stillbirth. Everything is going on well, and suddenly this mishap happens and the baby dies. There's a lot of problems. It's an unpredictable obstetric emergency, and timely delivery is the hallmark of good obstetric judgment. In India, especially, where in government hospitals where I worked, people have to travel a long way to reach hospital, and so fetal death occurs. It may be little different in private practice, where cesarean is much more common, so the incidence of cord prolapse is less. Next. So what is cord prolapse? It's defined as descent of the cord into the lower uterine segment, where it may lie either below the presenting part, either the head or the breech, or beside the presenting part, without the intact fetal membranes. So the membranes have ruptured, there is a small gap somewhere, and the cord comes down. So either it may be by the side or it may come below, and then the condition is called cord prolapse. If this happens with full cervical dilatation, then the term changes to cord expression. And when the membranes are intact and the cord has come down, it is called as cord presentation. So these are just words which we ask in exams to undergraduate. The treatment is mostly the same in all the conditions. Next. There is a condition called as occult cord prolapse, where actually there is cord prolapse, but we cannot diagnose it. It cannot be palpated, and suddenly there is a fetal distress, and we are wondering what has happened. Or there could be a compound cord prolapse where the cord and an arm or a leg comes down. So it's called compound cord presentation. Then there is a called a phonic chord presentation, where the same as chord presentation, but the other word is phonic presentation, where the chord can be palpated below the membranes, inside the membranes. And chord prolapse, of course, is cord lies in vagina with membrane rupture below the presenting part. The incidence of cord prolapse is unknown because we can't diagnose occult cord prolapse. But it is less in cephalic and frank breech because in these two conditions, the presenting part fits well into the pelvis. So there is no place for the cord to come down. But where there is a little place, the cord can come down, especially it's 5% in complete breech, 15% in footling breech. That's why we tell that all footlings must have, of course, we tell all breeches should go for cesarean, but previously at least footling breech was compulsory cesarean section because the incidence of cord prolapse is very high. And of course, in transverse lie, when there's no presenting part, there's a lot of space for the cord to come down. The common etiology is incomplete fitting of the presenting part into the pelvis at the time of rupture of membrane. So one has to be very careful when we do ARM because one of the most important complication is cord prolapse. So what are the fetal factors? Most important is malpresentation. But nowadays, no one is doing vaginal delivery, so it's becoming less. So any malpresentation, breech, face, bro, we are hardly seeing them. All are gone for cesarean section. So the incidence is becoming less. Fetal anomalies, especially anencephaly. I remember in my undergraduate days, postgraduate days, when when sonography was not so much available in labor room, we would be so excited when the cord prolapse comes that we'd rush for cesarean section. Only to our bad luck that it's a anencephaly. So one should be very careful that there's no fetal anomaly because in the hurry of going for cesarean section, and if there is no sonography, which is unlikely these days, we may miss some mishap. Then if the baby is very small, baby's head is small, there's a lot of liquor, so the fetus, the cord can come down. And especially twins, after the first baby is delivered and there's a second baby, there's a lot of place in the pelvis, and the baby, second baby is small, so again the cord can come, we should be aware. The maternal factors, of course, early rupture of membranes, spontaneous, suddenly there's a gush of liquor, and if the presenting part असं व्यवस्थित बसलं नसेल, the cord खाली येतो. Preterm labor, I told you again, baby is small, head is small, lot of place, there can be cord prolapse. And pelvic tumors like fibroids, etc., and the presenting part cannot come in the down, presenting part may be somewhere in the side, etc. So the pelvic part may be empty and the cord can come down. Placental factors, of course, polyhydramnios and a minor degrees of placenta previa, because in minor degrees of placenta, major degrees, of course, there is no place, but minor like presenting part and the cord can come down. Cord abnormalities, low content of water in jellies may increase the cord turgidity and make it more, the strength of the cord may be more, so it can push its way below the presenting part. And of course, long cord, we are taught that it can prolapse or it can bind around the neck or any part because there's a lot of cord. No, a cord should be between 25 to 50 centimeter. More than 50 centimeter is a long cord. Now, very important is iatrogenic causes, especially in this medical legal era. So the most important, of course, ARM. So we always teach that after rupture of membranes, of course, one should rupture membranes only after the presenting part is well fitted. And after rupture, one must check that there's no cord because 57% occur within 5 minutes of ARM, while 67 occurs within 1 hour of ARM. So one should be aware that after ARM, if suddenly the fetal heart is showing some problem, there's brady or there is a little irregular heart rate, one must not forget cord prolapse. So if the presenting part is not fixed, we must fix it with the other hand and then only do ARM, or best to do a needle ARM so that the liquor comes out slowly and there is no sudden gush of liquor. Procedures like ECV, IPV, nowadays we are not doing all this, unfortunately. So when we do move the baby like that, the cord can also move and come down. And placement of balloon catheter for cervical ripening. So when we put Foley's, etc., we may displace the presenting part if it is a preterm, etc., and the cord can come down. And we don't do it much, but abroad, when we apply a fetal scalp electrode, again the presenting part thoda sa वर ढकललं जातं and the cord can come down. Next. So what are the consequences? The cord comes down, the cord gets pressed by the presenting part against the bone, and the vessels outside of the vein and inside of the arteries, they get compressed. So, or if the cord comes down, the vaginal temperature is much colder. So there is a vasospasm. So the blood supply to the baby is cut off and there is birth asphyxia. This can cause death or even it can cause cerebral palsy. So when do we suspect? Suspect when the changes occur after membrane rupture. Very important. Either on its own if the lady starts leaking or when we do ARM. And how you confirm? You just do a PV immediately. So either you will feel a cord below the presenting part or you will feel a cord-like structure inside the membranes. So there is a pulsating structure in the vagina, or visibly sometimes it comes outside only. Then anyone can diagnose it. This is accompanied by bradycardia or severe variable decelerations. So though sometimes what happens even after all this, by the patient's luck, the fetal heart may not change. And the presence of a limp, pulseless cord does not mean fetal death. So we have to always auscultate and do a sonography because fetal cardiac activity should be judged because sometimes the cord may be pulseless because of the cold temperature, but we should not lose hope, but do urgent sonography. What is the differential diagnosis? The potential causes of a palpable mass include fetal malpresentation, like fetal arm, fetal limb, etc. And when there's a sudden brady, we must think of hypotension, uterine rupture, vasa previa, and abruption. So these also should be thought of because all these are the causes of sudden brady. So as soon as you diagnose, you should try to push the cord above the presenting part. An interval to phonic decompression may be more important to outcome than interval to delivery. So suppose you can't deliver the patient within the next 20 to 30 minutes, at least try to prevent the compression of the cord. Most urgent delivery is required in cases of bradycardia because the cord pH declines significantly with bradycardia to delivery interval, and this may indicate an irreversible pathology such as vasospasm or persistent cord compression. However, cord arterial pH does not correlate with deceleration to delivery interval, indicating that intermittent cord compression causing deceleration is reversible and less risky. Means we should try to decrease the compression on the cord. This will prevent the hypoxia to the baby. So in occult cord prolapse, suddenly we don't know that cord has prolapsed. We should suddenly there is a bradycardia, quickly put the patient in left lateral so that the blood supply to uterus is improved. Give her oxygen, start IV fluids. If there's a hypotension that will come up. If there's any oxytocin, immediately stop it. Continuously monitor the heart. Previously, people used to do amnio infusions, etc., to decrease the pressure on the cord. But now everyone, as soon as possible, we do cesarean section, even if the fetal abnormalities persist. Now in cord presentation, the cord has come below the presenting part, but luckily for us, membranes are intact. This is a slightly better condition. The increased use of antepartum obstetric ultrasound, especially with Doppler, has assisted us in making the decision of a presenting cord and preparing for cesarean section. Every patient with fetal malpresentation, twins, prematurity should undergo ultrasound before labor to rule out cord presentation. So whenever we know these conditions, we must get a sonography. And nowadays the sonographies are so good, especially with Doppler, that they tell us that there is a cord below the presenting part, beside the presenting part, and we will always do cesarean. We will not wait at all. But if an overt cord prolapse, speed is essence, and perinatal outcome is determined by how you deliver the patient as fast as possible. The three components are relieve the compression and vasospasm, check out the fetus, whether it's alive, dead, whether it's abnormal or something, and quickly deliver the fetus. So these are the three things, and it has to be done as fast as possible. So the first thing, if you can't do anything, put your gloved finger and lift the presenting part. So if you are the main doctor, your assistant can do this, because even taking for cesarean takes at least 15 to 20 minutes. It cannot be faster than that. So till the cesarean patient baby is out, someone can put their hand in the vagina and lift the presenting part. Second, and with gentle handling, the cord should be reposed back in vagina. Suppose it's come outside, then at least put it in the vagina and pack the vagina with gauze, so that the cord will not be subject to the cold temperature. That will make the situation even worse. And there is a Vago technique where you put a Foley's and fill the bladder with 500 ml of normal saline. So what will happen is, when the bladder enlarges, the presenting part automatically gets pushed up and the pressure on the cord will decrease. And if possible, you can give her a subcutaneous tocolytic like ritodrine, etc., so that if the patient is in labor, the contractions will decrease and the pressure of the presenting part getting pushed down on the cord will become less.
मुझे कोई इशू नहीं आपको सिर्फ यहाँ पे नेटवर्क का इशू है मैं कहीं और मैं बोल रही थी आपको कि मैं मैं करती हूँ लाइन के थ्रू कनेक्ट कर रहे तो आपके लिए एक जाए
कनेक्शन लगाना पड़ेगा
कुछ नहीं आप सिर्फ मुझे
Yeah, thanks, Kundan. Different positions were recommended in the past because cesarean would take time. Now, also in the traffic, if you have a small nursing home, for anesthetists to come, it's different in corporates where there are always anesthetists. But in small nursing homes, for the doctor to reach takes time. So you can put the patient, though it's अवघड वाटतं हे genu pectoral, but you can definitely give her a head low or put her in the lateral position to decrease the pressure on the cord. Now check out the fetus if you have a sonography in the labor room, nothing like it, or see her previous report in the file, whether there's any abnormality, what is the gestational age. Because we can't deliver very pre-viable fetuses, etc., because then the prognosis is equally bad. So you must check out how is the baby before you rush, because we are so excited, we rush for cesarean section. We forget sometimes that how is the baby. If cervix is fully dilated, very easy. Quickly, you can apply a forceps. It's said that vaginal vacuum is less second number, because forceps is really fast. Within 2 to 3 minutes, we can apply a forceps if the head is low down. But if the head is slightly higher, then we'll have to use a vacuum so that the delivery occurs within 20 minutes. And if it's a breech, then of course, previously we would give anesthesia and do an extraction. But now I think breaches are done planned cesarean section, so this occasion may not come. And if cervix is not fully dilated, we have to do an emergency cesarean as soon as possible. It is said that within 20 to 30 minutes, till that time, someone will, even during the induction, ideally we should give general anesthesia. But nowadays people are doing under spinal, very fast spinal, but you have to keep your fingers in vagina and keep the presenting part up. You have already filled the bladder, but be careful to empty the bladder before taking incision. Always check fetal heart before the induction, because sometimes baby may have died, and quick spinal should be done. And there should always be a very good neonatologist, because many times these babies are floppy, they have low Apgar, and they may need a good resuscitation. If cord prolapse occurs outside the hospital, patient should be given head low in the ambulance, and head should be elevated in transit of the baby, either with a finger or a full bladder, because till she reaches the cesarean section hospital, it should be the presenting part should be lifted. So how is to prevent this? Always all women, especially high risk like twins, malpresentation, should have sonography. Women with transverse oblique lie, unstable lie should be offered elective cesarean. We all are doing this, so this is important for all of us. Women with PPROM should be admitted and regularly monitored, because during the admission also the cord can prolapse. So you should have at least 6 hourly CTGs so that you'll know if there's some changes in the heart. bradycardia or variable deceleration should undergo immediate PV. So we always teach residents, see if there is a sudden bradycardia for no obvious reason, think of cord prolapse. Avoid ARM if the presenting part is not very well fixed. Fix it and then do the ARM. If it is necessary to perform ARMs, it should be done after fixing head and keeping OT available. And also, as I said previously, you can do with a needle so that there is a slow drainage of liquor and no sudden gush and the cord cannot come out. Most important is postnatal debriefing because the women are so worried, they're not anticipated, and suddenly they are rushed, they are not planned, nothing. Poor lady, suddenly she comes, all the doctors are after her. Someone is putting their finger in her vagina. It's painful. She's rushed for cesarean section, and she has never been told this in her whole ANC. So debriefing should be done. And if they have come long distances from some periphery, and if they've been rushed for Caesar, and if they had a stillbirth or a baby in the NICU, they'll be severely psychological traumatized and they need a lot of counseling. So cord prolapse is a life-threatening condition for the baby that occurs in labor. And I don't think any of us ever tell all this to the patient because it's rare and it's sudden. So we also don't know. And rapid identification and immediate management may save the life of the neonates, though still many times we may lose the baby either fresh stillborn or in the NICU. Next. So I thank you. It was a very simple topic. And thank you, Dr. Madan, Dr. Rachna, Dr. Prerna. Thank you all for helping me out. Thank you so much.
Dr. Uma, I think it was though it looks like a very simple topic, but I think when it happens, I think it's a nightmare for the patient as well as for us as a clinician. But I think you have beautifully covered the very important points at this such a emergency hour. I'm sorry I was not able to join because of the poor network. I'm in Katni, joining from Katni for your talk, especially. But I think for all the delegates, I think it is very important that the diagnosis of cord prolapse. Sometimes it does happen that even the diagnosis is not immediately happens because the cord is not really seen outside and there is just a fetal distress. So even that can happen. So I think having vigilant mind and a strong suspicion about whenever you see a fetal distress in such scenario, I think always check for the cord prolapse and which is not even evident or concealed, revealed outside the introitus. So that is also very important. Any other comments from my co-chairperson? So you can please take it now.
Vaishali, madam.
Yes. Hello, madam. It is very nice that even after 25 years, Uma ma'am's teaching is just as clear, knowledgeable, and enjoyable as for the first time.
Thank you so much.
Never change. Yes, madam. Nice to see you after so many years.
Yes, even I have very good memories of Jalgaon.
Yes, madam. Thank you.
I think we have Dr. Sanjay Zadav sir as well. Sir, would you like to add something? Renuka ma'am, do you want to add something?
Thank you, Uma ma'am. It was an excellent talk. And though it might seem as the option is a cesarean section, we all know, but having a high degree of suspicion whenever the FHS drops needs to be reiterated and reminded to all of us again. So thank you very much, Uma madam, once again.
Thank you so much. Thank you.
Can I ask you one question?
Yes.
Yeah. See, as a professor, for the emergencies like cord prolapse. So now usually the resident when informs you as a postgraduate resident that, okay, there is a cord prolapse and you are very far away from the hospital. Sometimes you cannot reach. What is your first instruction to the PG, or what exactly you tell your PG to do it to save the fetus? And, what is the advice you first give to the PG resident?
The only advice we give is rush for cesarean section.
Rush for the cesarean section. I think that's That's very important thing, I think, and that is what is we need to really take it at a pinch of salt. That yes, as early as possible, even if you are not there,
Hello.
somebody who is qualified and accessible to do the cesarean section immediately, I think you need to allow it to happen, because that is what is something. Because sometimes if it does happen that we do have postgraduates working with us and we are not confident they can they do the cesarean section, but I think let them allow, at least they will be able to deliver the fetus. Rest of the complications you can reach and
We
manage.
can manage.
Yes, I think that is very, very important message. So thank you, Dr. Uma, once again for a fantastic brief your presentation about cord prolapse. And Madan, thank you for inviting all of us, Dr. Renuka, Sanjay, Dr. Vaishali, on my behalf for having us as a chairperson. Thank you very much.
Yes. Thank you, Kundan. And thank you, Uma ma'am. It was really
Thank you.
excellent presentation. I think Dr. Sanjay sir wants to say something.
Yeah, am I audible? Am I audible?
Yes, sir.
Yes, sir. Yes,
You,
sir.
you can make your video on.
No,
Proceed.
I don't want to make my video on. I just wanted to add something
Okay, sir.
regarding the medical legal aspects of this particular complication. Hello? Can you hear me?
Yes,
Yes,
sir.
sir. We
Yes,
can
you're
hear
audible.
you.
Yeah, I just wanted to add one thing, that medical legal aspects of this particular complication are devastating nowadays, especially in today's scenario. So, madam, तुम्ही काय ऍड करू शकता का याच्यावरती?
नाही, मी एवढंच म्हणू शकते की डॉक्युमेंटेशन ऑफ द इव्हेंट, बिकॉज
हा
इट्स
event जेव्हा
रिअली
होतो,
अनप्रिडिक्टेबल इव्हेंट. तर
तेव्हा
जेव्हा वी हॅव
कळत असतो
वी
सगळे. आणि प्रायव्हेट जर हॉस्पिटल असेल पर्सनल लेवलवरती खूप पळापळी करावी लागते. त्यावेळेस हे सगळं डॉक्युमेंटेशन वगैरे सगळं करत बसणं म्हणजे प्रॉब्लेमॅटिक असतं.
So
नाही
can I
नंतर
comment on this? So
Sir, one more thing I would like to add.
yes.
Bolu ka?
Oh,
Am I
go ahead.
audible?
Yes, please.
Legally recognizing cord prolapse is important first thing. Then documenting and informing the relatives and the patient that this has happened, and we will try to get the baby out as soon as possible and do whatever is necessary. This documenting is important. Otherwise, if it goes unrecognized and if it is a stillbirth, then the big issue may occur.
Okay. Just one addition regarding this, that, even if you're busy in managing this patient, you can ask any of your colleague from your hospital to have a 1 minute word with the relative. Even once you have informed the situation and the husband has given a consent for cesarean section, believe me, the 99% problems will be solved. You don't need a documented consent in this case situation. You need an informed consent that you have informed
Informing
them.
is important.
It's very important, because they should have, once see, as a relative, once they have the gravity of the situation, who is going to say no to your management? Okay, so it takes 1 minute to just inform. May not be you yourself, but somebody or your colleague or anesthetist go and talk to the patient and tell them that this is the situation and needs to be done. I think nobody will get, but not informing is the problem. When you don't inform and then go with cesarean section, and if really there is a fetal compromise, then is the issue, because you cannot explain, because patients are not ready mentally that what was the situation. I think that's
and
from my
if you
side.
if the cord is prolapsed, you can show that to the relative.
Yes, absolutely. You can just even take a photograph and give
Yeah,
it.
yeah.
No problem.
Yeah. So can I add something here?
Yes.
Yes, yes, madam.
Let's go.
Yeah, so actually, this was a very relevant question that Dr. Sanjay has put forth, that especially in private practice, because you are someone, you are like the one-man army many times, and then you are, or I mean, you are directing people all over, and there's not enough time to really explain what happened. So I think one thing that we all can do is, again, I go back to that proxy consents have been made, and they have a wonderful consent for normal delivery and cesarean section. The ideal thing would be there that if, the moment your patient enters 37 weeks, please hand it over to them and ask them to read it. They have to read it and they have to carry it when they come back to the hospital. That tells you all the complications that are likely to happen in labor, pre-labor, and after labor. Simple thing that we have, it is all on the net. Now we have Nasik has made it in Marathi also. So there is no problem. All your patients have to just hand it over. Hey, माहिती पत्रक मला या दिवशी मिळाले, and just give it to them. it will, that few pages of Xerox that you need to do, I think it can save you a lot of headache. Of course, jo hona hai, that will come. Sometimes there are some things backfire, but what we can optimize is ideally is to give the consent form right when the patient is at 34, 35, 36, whatever, depending on what you think is the problem. Sometimes even after that, also things happen. But the utmost precautions that I think as a private practitioner, we can really do something about this.
I think Dr. Gauri, absolutely fantastic statement. That's a very important thing that you have given idea, at least information about what can go wrong at a state when there is no complication right now. So that's something, it's like a preventive strategy. And I think that's a very valid, and Foxy do have a such consent, which we, anybody can share with your patient by 36 weeks or 37 weeks, even before the labor starts. So probably, yes, I think that's a very value-added statement by Dr. Gauri. And thank you, Dr. Manisha, for your comment also. I think we can proceed for the next session. Thank you,
Yes.
Dr. Uma, once again.
Yes. Yes. Yes,
Thank
thank
you.
you. Yeah, wonderful inputs from all
Thank you,
the
sir.
chairpersons. Yeah. Rachana? Yeah, Prerna, please continue.
Thank you, esteemed chairpersons and our respected speaker for a wonderful and insightful session. We now move on to our second session, that will be infections in cesarean section, preventing the postpartum morbidity. To chair this very esteemed session, we have our very revered G.V. Rathod sir, President Buldana Society, Dr. Jitendra Kumar is President Dr. Aramati Society. I now request one of our chairpersons to kindly introduce our very revered speaker, Dr. Gorandikar Madam, past president of Nasik. Over to you, sir. Rathod sir, if you're there. Any other chairpersons, if you are available, Dr. Jitendra sir, Varsha madam. Logged in?
No, I think no chairperson has joined.
So I take the honors of introducing Dr. Gauri Karandikar madam, past president of Nashik OBGYN Society. Madam is currently managing director and lead consultant, Karandikar Hospital, Nasik, and she has been the managing committee board member of PCO Society of India and has multiple awards and affiliations to her credit. We are so very honored to have you, ma'am, amongst us, and the dais is all yours, madam.
Thank you, Prerna. Can I share my screen?
Yes, madam.
So good evening, everyone. I hope I'm audible. So at the outset, I would like to congratulate Dr. Amey Purandare, President Amogs, and Rohan for initiating this wonderful webinar series. And also thank you to Dr. Asha Dalal and Dr. Varsha Baste for her kind words, and Dr. Suvarna, Dr. Madhuri Patel. All of you have really enriched this session by your presence. And thank you to the coordinators for today, Dr. Madan Kamble and Prerna, and Dr. Rachna also, for inviting me for this webinar. And wonderful presentation, Dr. Uma. Always a pleasure to hear her, and such relevant points, that have come from her. Thank you so much. Now, she's made my job simple that, we have already entered into the cesarean section, because this is like a cord prolapse is like an undisputed indication for cesarean section. So we have no doubt whether the section was indicated or not. So we have moved into the indicated section. And today we are going to talk about basically what are we likely to do for prevention and management of infectious morbidity. Now, one thing is that why is it so important that we are talking about this issue? That we know that the surgical rates are increasing. The global C-section rate is 21% worldwide. In India, in the private sector, is almost 40 to 60%. Almost 7% of these C-sections, there is surgical site infections, and 75,000 maternal deaths per year are linked to postpartum sepsis. Again, we are coming into an era where there is a threat of the antimicrobial resistance, and we don't know where we are proceeding, but we have to really face it. And a time will come, say by 2050, when this is going to become a real worldwide problem. So we need to know and what we can do to prevent C-sections, which is the rates are increasing and the morbidity and mortality is also very high. So recently in 2025, we had this FIGO committee on infections in pregnancy, and Dr. Mandakini Make from India, she's a committee member, and we had the other members, and I was also part of the subcommittee. And we have released this article. I would, if any of you would want to go back and read this article, it's on the web on reducing post C-section sepsis or FIGO. Please, this is something which we have come together from worldwide and put down these guidelines for reducing post C-section sepsis. And I was one of the first authors for this special article. So what are the primary threats that we are looking in post-cesarean recovery? The one is what we are looking at is the surgical site infection, which is generally between 3 to 30 days post-operatively. Seen in 2 to 20.5% of cases, they are the superficial, deep, incisional, or any infection right up to the fascia. Then endometritis, which starts from 10 days postpartum, and the incidence is high, almost 1 to 3 times higher, 1 to 3%, but 10 times higher post C-section with a polymicrobial involvement. Urinary tract infection post C-section generally seen within 30 days, 2 to 16% of incidence, and often catheter-associated E. coli, which are the most common and generally goes under-recognized. And post C-section sepsis, which can occur in say 0.1 to 2% of cases, which is life-threatening, and it meets sepsis 3 criteria, and it is one of the reasons why of ICU admissions. So when we go into the stepwise prevention, the first is to understand the risk stratification and optimization. So what are the risks that we are going to look at is the modifiable risk that we could actually work on, say obesity, diabetes, nutritional anemia. Then the obstetric and labor room constraints that we have, that is prolonged PROM, prolonged labor, multiple vaginal examinations, GBS colonization, and surgical constraints. So if we go into the risk factor identification, we can classify them into the preoperative, intraoperative, and postoperative. Preoperative is which we can stratify those risks for obesity, diabetes mellitus. We see the GDM, the rates are increasing day by day. Anemia, something very preventable, and anemia is seen across all sections of society. HIV or any immunosuppression, patients on immunosuppressants for any autoimmune disorders, previous surgical site infections, prolonged PROM, prolonged labor, and multiple vaginal examinations through labor. Intraoperative, an emergency C-section, chorioamnionitis, prolonged operative time more than 60 minutes, excessive blood loss, inadequate antibiotic prophylaxis, to which I will come a little later, suboptimal skin preparation, large incision length, and a second stage C-section. Postoperative is again a wound hematoma, premature removal of dressing, poor wound hygiene, prolonged catheterization, nutritional deficiency, and very important is a delayed recognition of SSI. Now, the pre-incision prophylaxis algorithm, what does it tell us? That there's a golden window, and that golden window timeline tells us that if it's an elective C-section, give the antibiotic before the incision. In an emergency, give it without delay. So 30 to 60 minutes before skin incision is known to reduce the incidence of C-section sepsis drastically. Along with that, we have the decision tree that select the prophylaxis, any standard patient without major any risk factors, any cephalosporin first generation, it works well. There is no need to go to higher antibiotics. A single IV 1 gram dose is sufficient. As the BMI increases, increase the dose of the antibiotic. In case of prolonged PROM, add azithromycin pre-incision. In chorioamnionitis, ampicillin, gentamicin works well. And in MRSA risk, add vancomycin. It is not necessary to repeat doses unless the surgery has exceeded 3 hours. A routine post-op prophylaxis adds zero benefit, and it is worsening the AMR risk in these patients. In fact, it's increasing it worldwide. Next is a very important surgical principles that we need to follow and teach our residents, teach juniors, teach our staff. That is skin preparation. Use chlorhexidine alcohol over povidone iodine alone and allow a 3-minute drying time. Clean the umbilicus separately. Now, this sounds like really basic, but these are small things that they have been found by the WHO and the Surviving Sepsis campaign also, which have shown that these small things really improves the outcome. Prefer clippers over razors if hair removal is essential. Preparation of the vagina, which even I wasn't doing till quite a time actually, where we do a vaginal wash pre-cesarean section. Normally we do a vaginal mopping post section, but this is recommended that a pre-C-section cleaning of the vagina, it reduces the post-C-section endometritis by more than 50%, especially in PROM cases. A simple change, that is a glove change mandate. The change gloves after placental delivery and before closure of the abdomen. It changes the whole milieu and it reduces the C-section rate tremendously. Then evidence-based wound closure mechanics, very important. Subcutaneous fat protocol. No, people are in a hurry. I don't know why we are in such a hurry and don't want to close layers. I think we can still close layers and respect tissue and close the layers as it comes. So mandatory closure if the fat layer is more than 2 centimeters. This reduces SSI and seroma formation. Subcuticular sutures are equally good, in fact, good for skin closure. Surgical staples versus vicryl, still it is almost the same. There is not much difference. Routine wound drains are really not required, and minimize operative time. More than 60 minutes acts as a critical multiplier for SSI risk. Post-operative management, very important in the ward. There's a 24 to 48-hour window before the patient actually goes into sepsis. So what is important is ensure strict wound hygiene. How they are how we are managing their catheters, how we are managing the wounds, how we are looking at the dressings. It is very important, and address any nutritional deficiency immediately. Clinical monitoring, very important. Look for the first rise of temperature. Look for tachycardia, simple clinical parameters. Uncharacteristic lower abdominal pain, which we know that which is not normal that we see in any C-section. Something more that we are looking at, patient is explaining to us. And also discharge education, that is like even Manyata talks about, where you give them the danger signs. At discharge, it is very important to talk to the patient, give them a list of what are the danger signs that they should look for, any erythema, fever, discharge. All these are very important because a delay in recognition is going to make it worse. Simple diagnostic triage that we've taken picked it up from the NICE guidelines also. A green, like it's like a traffic light clinical matrix. Green is a local so talks about a local infection, just wound erythema, localized cellulitis, temperature more than 38 degrees within the first 24 hours only. No systemic signs. This is simple, just ward wound care, just oral antibiotic, needs close monitoring. Temperature more than 38, beyond 48 hours, tachycardia, rising CBC count, uterine tenderness, all these we need some action, that is IV antibiotics, cultures, and a pelvic ultrasound. A red light is a sepsis or septic shock where we look for the SOFA score, anything more than 2. It is a quick bedside SOFA, that is Q SOFA more than 2, a systolic blood pressure less than 90, mean arterial pressure less than 65, lactate more than 2, or altered mental state. So we need to look for the respiratory rate, look for the blood pressure, look for the mental signs. If anything is deteriorated, anything more than 2, it's a sign that we need to act fast and that we need to escalate the care to HDU, ICU, and don't wait in your own nursing homes. Let me see, let me watch. Sepsis moves fast and we also need to move faster. So what are simple rules for preventing endometritis? So if there is a sign of infection, open, explore, remove the sutures, debride the necrotic tissue, obtain a swab for culture sensitivity, irrigate, don't use hydrogen peroxide for deep wounds, wet dry dressing for a superficial wound, and vacuum dressings for a deeper wounds. Mild infections, amoxiclav works well, moderate go for cephalosporin. Only in severe infections, carbapenems are really required. For endometritis, first line, clindamycin works well. Whenever I speak to a lot of doctors, they are really hesitant to use clindamycin. Clindamycin is a wonderful antibiotic in pelvic infections, and it really works very well. So clindamycin and gentamicin works well. Alternatively, ampi-sulbactam is also a very good alternative. switch to oral after the patient has been afebrile for 48 hours, and always do an ultrasound to rule out any retained products or hematoma to be on the safer side. Now, it's important to know how that the sepsis escalates, moving from local infection to multi-organ dysfunction. So the definition of sepsis now has been the sepsis is not only a severe infection, it is a life-threatening organ dysfunction which is caused by a dysregulated host response. So what we have to pick up is the dysregulated host response. We have to pick up the signs that the host is giving us, the signs that the patient is giving us, the output, the tachycardia, the blood pressure, the mental status. Very important. You don't have to wait for any lab results. Any trigger emergency protocols of any two of the three criteria, that is a respiratory rate more than 22, altered mentation, or a systolic blood pressure less than 100, check for sepsis, don't wait. So time is critical. Every hour of delay in broad spectrum antibiotics increases maternal mortality by 7%. So you have the clock is ticking and we need to really move fast. So one is measure the lactate levels. High lactate levels are a sign of poor prognosis. Secondly is more and most important is draw the blood for blood cultures before giving the antibiotics, and then proceed for this, whether it is a wound, urine, or the or high vaginal swab as well. And a less than 45-minute delay is acceptable. Beyond that, no, we have to go for cultures, broad spectrum antibiotics and rapid IV crystalloids and vasopressors. Now we will not move into the ICU management, but because we are at the prevention stage. India, very important that we are taking this. Congratulations, Amir, for really taking these Surakshit Matritva series. And in fact, I would urge you that you can even circulate these lectures, these talks, or these invitations to medical officers working all over in the PHCs, because they are the ones who really have a hard time. A lot availability is a problem, and they also need to know this. So what is important is that AMR stewardship is non-negotiable. India is a global AMR hotspot, and with escape pathogens, and it is going to be a difficult scene in some years, even for ourselves when we grow older. I think antibiotic resistance is going to be a big menace. So it's important to avoid empirical higher antibiotics as first line. De-escalate antibiotics within 48 to 72 hours based on cultures. Resource allocation, simple, that 2% chlorhexidine, it's not universal in primary health centers, and it's important. Just one small step of pre-C-section cleaning of the vagina, changing of the gloves, are simple things which can be done from a primary health center to any hospital. Patient optimization, anemia, check for anemia. It's a modifiable risk factor. Preoperative iron, hemoglobin optimization, it should be made a must prior to any elective C-section. Very important, reduce unwarranted C-sections. Standardize labor management, go for the WHO protocols for labor management. Utilize the FHR assessment tools. Look for CTGs. Maximize second stage support. What we are really worried about is what if something goes wrong. So like I said some time ago, look at the consents, ask for help immediately, but standardize your labor management, and look for where we can delay the C-sections. Promote VBAC if wherever possible. Trial of labor generally gives a 60 to 80% success rate. If appropriately patient is selected, a scar ultrasound is now getting more and more helpful, and it is important to counsel these patients against liberal C-section, on-demand C-sections. Another important thing is audit your own hospital, audit your own practice, audit your own department with Robson's classification, and see where this could have been prevented. That 1 to 5 group, especially in Robson, is where we can really do it. So coming to the last blueprint is pre-op, stratify the risk, pre-incision, prepare well, give the pre-antibiotic 1 dose before incision or immediately, and utilize a higher doses for PROM or obesity, or I would say BMI more than 35 to 40, intra cleaning of the vagina, mandatory glove closure of subcuticular fat, post-operatively monitor the patient, look at the patient. Patient is always giving us signs. And then if you have a traffic light, you need to know whether you're in the red, amber, or a green, and then, activate the 1 hour bundle immediately. Because every life matters, whether, it's important that we have to save every life. Just like Dr. Suvarna said, Dr. Suvarna Khadilkar said that we have to aim at no SDG or no goal. We have to come to work that every life is the goal and we have to work towards it. So thank you so much for a patient listening. I would stop sharing.
Excellent lecture, ma'am. The 5-point approach was too good. And I would like the chairpersons to have, I would like to have a word from chairpersons. I think no one has joined. Moving towards our third session, which is on panel, which is a panel discussion. The moderator are Dr. Nalini Bagal, madam. She's Chief Madam, President Nashik OBGY Society. And we have expert Dr. Narendra Zope, sir, who is President of the Chalisgaon. President Chalisgaon Society. The panel discussion is on a very important topic. That the panelists for today are. Can we have a slide for panelists? Next slide. Yeah. The panelists for today are Dr. Surya Kumar Thandare, sir, Dr. Vishal, who is Secretary Satara OBGY Society, Dr. Vishal Patil, sir, Secretary Dhule OBGY Society, Dr. Mayur Shah, sir, President Malegaon OBGY Society, Dr. Sachin Khedkar, sir, who is Secretary Chalisgaon Society, Dr. Neelam Bagal, madam, who is Secretary of the Ahmednagar Society, Dr. Kiran Razore from Nashik OBGY Society, Dr. Sai Borbake from Loni OBGY Society, and Dr. Tushar Gadade, sir, from who's Secretary Baramati OBGY Society. So I request Nalini madam to take over from here. And I request all the panelists to please put on the camera so that we know who all have logged in for this panel discussion.
First of all, thank you very much for the Dr. Madan, Dr. Rachna, and
Hello.
Hello. Hello.
Yeah, ma'am, you're
am I
audible.
audible? Yeah.
Yeah.
So thank you very much, Madan, Prerna, Rachna, for inviting me and giving me opportunity to moderate this session. Welcome all panelists. I'll be sharing my screen. I can't share the screen.
We'll have to close the windows and again open that window and start screen sharing.
Okay. I'll leave meeting.
No, you don't have to leave the meeting. You'll have to close windows on your PC first.
Okay.
And then you have to press the screen share option and then again open your PPT.
Yes.
Mr. Rakesh, can you help ma'am with screen sharing?
Yes.
Yeah, please.
Ma'am, may I know exactly what you are facing? Means on the button, there
Yeah.
will be a share button will be there.
Yeah, share button. I have seen
Yeah.
that.
So click on that. Click on that and yes, your presentation will be visible. Click on share button. There will be so many tabs might be populated and click on what exactly presentations you are going to present.
Okay.
That one.
I can't zoom that Zoom.
Do you have that presentation in your phone so that we can share it on our end?
See, it is there on the desktop only.
Achha.
So I can share it. I'll log out and again I can log in. Is it okay?
Yeah, ma'am.
Otherwise,
Yes,
I'll
ma'am.
not be able to. Yeah. Okay. Can you see? Is it
No, ma'am.
visible?
No. No.
No.
Ma'am, can you mail it? Mail it to, or can you share it in the group?
Okay. हॅलो हो तेच करते आता
Ma'am, can I add something, ma'am?
Yes.
Ma'am, actually, if there will be no issues, you can share your presentation to us so that we can present that. So it will
Yes,
be easy for you
yes,
then.
that will be easy for me then.
Yeah, yes.
I'll open my. I'll mail it rather.
Yeah. Rachna ma'am, shall I share my mail ID so that ma'am can share or you are going to
No,
share?
you can share it. Dr.
I
Mr.
can
Okay,
share
Rakesh
okay.
can
your
share it.
mail ID.
Yes, ma'am.
Ma'am, on your WhatsApp number, I'm going to share my mail ID so you can share me. Ma'am, I have shared my mail ID on your WhatsApp number so you can
Okay.
share your presentation. Yes, ma'am.
I'll wait.
Hello.
Rakesh, no?
Yes, ma'am. Yes.
Just say whether it has come or not. Just confirm, Rakesh.
Yeah, ma'am. I've received.
It is there, no? On the WhatsApp only I have sent you.
Nope, no issue, ma'am. No issue.
Did you get that?
Yeah, ma'am. Just now I'm opening the slides.
Okay.
Ma'am, I believe it is visible to you, to all. Rachna, ma'am?
Yes, Mr. Rakesh,
Yeah.
slides are visible. Yeah.
Okay, thank you. Ma'am, you can continue.
Yeah. Next. So welcome all brilliant panelists. That is Vishal Patil, Dr. Vishal Patil from Dhule. He's president of Dhule OBGY Society. Surya Kumar Khandare from Satara. Dr. Mayur Shah from Malega. Dr. Neelam Bagal from Ahilya Nagar. Dr. Kiran Rajole, she is our Nasik VP. Dr. Sai Boravke from Loni. Dr. Sachin Khedkar from Chalisgaon. Dr. Tushar Gadagre from Baramati and the expert Dr. Narendra Zope sir from Chalisgaon. So welcome you all, and me and my co-moderator Dr. Manisha Jagtap will be moderating this panel. Next. So incidence of this tubal pregnancy is ectopic pregnancy is 11 in 1000 pregnancies. In ART, the incidence is increased to 2.5 to 4%. But nowadays, because of freeze-all technique, the incidence has been reduced right nowadays. Heterotrophic pregnancy incidence is 1 in 30,000. There are two types, that is the extrauterine and the intrauterine. Extrauterines are tubal, ovarian, abdominal. Intrauterine pregnancies are cervical, cornual, or scar pregnancy. Next. Most common is fallopian tube pregnancy. So what are the common symptoms you will be getting, Dr. Kiran?
Hello, good evening. Thank you,
Yeah.
madam, for taking me on this panel, and I thank of the whole team. So I think we have lost time, so I straight away go with the common symptoms diagnosis. So you want me to talk about common symptoms, right?
Yeah.
Okay.
Common symptoms of
Symptoms,
ectopic.
yeah. So in the clinical scenario, most of the time, maybe the missed period, which may not be very evident. At times, we have seen, like in IVF pregnancies, there may not be the LMP missed. So there could be just a day missed or something. The nausea, pain, giddiness. There could be a simple symptoms of giddiness. Sometimes a light spotting and abdominal pain. But that pain is very typical of the pain with the giddiness. That kind of a syncopal thing which patient always complained. And when there is a kind of a amenorrhea, then it is a very typical symptoms of pain in abdomen with the giddiness, nausea, and
Right.
yeah, and
Sometimes
depending
there
on
will
the
not be
underlying
pain.
depending on the
Complete.
underlying causes, again additional symptoms can come.
Right. Sometimes there will be no complaint only. It might be there is
Yes,
a history of amenorrhea,
absolutely.
or history of amenorrhea may not be there.
We've
So
seen cases where even the date is tomorrow and she is burst today. So that kind of a thing also can be seen in that. Like it is
right.
always a
Perfect, Kiran. So how will you diagnose this ectopic pregnancy? What are the modalities? Sai, Dr. Sai? Bora, okay, sorry.
Bora, okay. Thank you,
Sorry,
ma'am.
Nancy.
Diagnosis, ma'am, weekly positive urine pregnancy test with a history of may or may not have missed period. Second thing is transvaginal ultrasonography, that is diagnostic. And again, the symptoms, the triad amenorrhea with discomfort in abdomen and PV spotting. So it should be a highly suspecting of ectopy, this triad, ectopic
Right.
pregnancy.
Right.
Can I add something? Because
Yes,
very
sure.
crucial to this ectopic pregnancy diagnosis, it's a beta HCG which we need to be, if you want to be
Beta
having
HCG,
the
beta
exact,
HCG.
the
Yeah.
diagnosis of ectopic, then you need to have that.
After 48 hours, we should repeat it, and if it's not doubled, so
The
ectopic
cutoff
is.
is the 66%. Like
Yeah.
if it is
It should
more
be
than
more than
66,
66.
this intried, yeah, 66% is a very crucial cutoff.
Perfect. Yeah. Anybody wants to add in this?
Ma'am, I'm Neelam Badal from
Yeah, Neelam.
Nagar.
Hello.
Sometimes patient may have history of sterilization operations, and she took that amenorrhea or missed period as a routine. So, history of asking whether any operative on tubes is important.
Exactly. That's a symptom. That history is must. If whether there is any tubal surgery, if there is past history of any past history of PID, if it is there, these are the risk factors which are
We have to
encountered
ask
during.
one important history of emergency contraception pills.
Right.
Yes, that is also important.
That is also important.
And IUCD
And-
in few cases also.
And for the diagnosis, it is the serum progesterone is to be done along with the beta HCG. So may I know who knows that what is the importance of serum progesterone in ectopic pregnancy?
Ma'am, serum progesterone, if it is less than 25, so actually clinical intrauterine pregnancy, it should be more than 25.
Yeah, right.
And if it is less, so maybe it's non-viable or can have a suspicion of ectopic.
So it is not the diagnostic for ectopic, but yes, whether it is viable or not non-viable pregnancy, that can be ruled out. Means if it is less than 5, then it is non-viable only. If it is between 5 to 10, then it is inconclusive. But more than 25, definitely there is a pregnancy which is viable. So serum progesterone is also necessary. And what is the role of MRI or CT in this ectopic pregnancy? Yes.
Usually it will help in diagnosing ectopic pregnancy, like heterotopic pregnancy or pregnancy or not on your usual side. Like sometimes we can see it in unwanted region also. And in case of cervical ectopic, it gives more useful information.
Exactly.
PUL, which is pregnancy of unknown location, which is a term which is used standardized. So for this, normally the MRI will be helpful. Or maybe I would say ovarian ectopic, where there you need to really find out whether it is a ovarian ectopic or a end tubal abortions. So that can be differentiated.
Mainly
And
the
also, ma'am,
rudimentary.
if it is to differentiate if it is car ectopic or it is a the
Yes.
sac that is expelled into cervix. So for that also MRI is needed.
Exactly. Secondly, if the pregnancy is there in the rudimentary horn of the uterus, then that is to be diagnosed with the help of MRI and confirm the diagnosis in that case. And again, the one indication is chronic ectopic. When you are not sure about the ectopic pregnancy, which is chronic one, then in that case also MRI is useful. Next. So in normal USG, what are the signs? Anybody? Whether you can tell? Is there
Normal USG,
Mayur?
intrauterine GSAC.
Mayur, just tell me in the normal sonography findings of the normal pregnancy, intrauterine pregnancy.
We have to assess her gestational sac diameter,
Right.
mean sac diameter. We have to assess the fetal heart activity,
Exactly.
fetal pole, and yolk sac. And
Yolk sac.
differential reaction, we have to see.
You're right.
Normally, in early pregnancy, we have to look all those things.
Yes, gestational sac, yolk sac, fetal pole, and if there are heartbeats are there or not, that is to be seen in the uterine cavity. Next slide.
And where it is located, because many times scar ectopy gets overdiagnosis at times if they are in the lower segment.
Right. That will come to that diagnosis. So the sonography, if there is a complex so what are the signs of extrauterine pregnancy? That is the ectopic pregnancy signs. Tubal pregnancy, ectopic tubal pregnancy.
Empty uterine cavity.
Right. First.
Adnexal mass with or without fetal heart activity. We have to assess the gestational sac diameter. Vascularity, we have to judge it on Doppler. Then we have to assess the free fluid in POD or in intraperitoneal side.
Right. So by the way, how will you measure the intraperitoneal bleeding? So if there is a fluid or blood collection is there in the Douglas pouch, it is almost around 500. If it is covering the uterus, then it is around 500 ml. And if it is going just below the liver, then it is around 2 to 2.5 liters
Morrison pouch.
of blood will be there.
Morrison pouch.
Hemoperitoneal bleeding. Sorry?
Blood in Morrison pouch.
Sorry? Can't hear
Blood
you.
Under the diaphragm, he's mentioning it
Under
is a
the
Morrison's
diaphragm,
pouch. Yeah.
Yeah, under the diaphragm and the Douglas pouch. These are the rough calculation which we are doing. So intraperitoneal bleeding is also diagnostic of something is wrong with the ectopic pregnancy. It is might be ruptured ectopic pregnancy. Next. So there are some few signs also. That is the tubal ring sign or donut sign, Bagel sign. There is an echogenic bright shadow that is surrounding the small empty sac in the fallopian tube. And you will be seeing that this is the Bagel sign. And a blob sign, only inhomogeneous irregular mass is seen in the adnexa that moves independently from the ovary. This is the most common appearance seen in the 60% of the cases. And the ring of fire. See here, there is a ring of fire around the sac. So this is confirmatory that this is the extrauterine sac.
Since we are talking about signs, there is one more barrel sign for cervical ectopic.
Yeah,
Yes.
that is the
Sonography.
hourglass
Hourglass appearance. Yeah.
type of sign. That will come there. First we'll discuss with the tubal pregnancy only, and then we'll come to cervical pregnancy. Next. Rakesh, next. So case number, Mrs. V, aged 25, married since 4 months, came to our hospital with a history of 35 days amenorrhea and mild over abdominal pain for confirmation of the pregnancy. Patient general condition is fair, 130/80 BP, no significant medical or surgical history is there. Abdomen is soft and UPT is positive. Serum beta HCG 565 on 2nd July, and repeat beta HCG is 996 milli international unit per ml. Next, repeat beta HCG is 297 on 10th of July, and repeat beta HCG again on 17th. After a week, it is 11 milli international unit. And on 24th, it is 2 milli international. Patient was asymptomatic, repeat scan was done, and SAC has reduced. So how will you manage this case? Means till 10th of July, how will you manage?
In this particular case, the beta HCG, initially it was a rise from 565 to 996. Here we have to think might be a viable pregnancy, might be more than 66% rise in beta HCG. But on 10th of the July, the beta HCG had dramatically fallen from 996 to 297. So it is a mostly a non-viable type of pregnancy we are trying to suspect, and we have to keep this follow-up in this case.
So it is the expected management with the patient is to be told about the follow-up after, say, 3 to 4 days, means twice a week she should follow. And if there is any emergency, that is severe pain in abdomen, if fainting is there, then she should contact hospital, right? Yes. Next. So this is the pregnancy of unknown location. Yes, Kiran, you can read.
Okay, when HCG test or urine pregnancy test is positive, but USG fails to confirm an intrauterine or retained products of conception or ectopic pregnancy, the woman is said to have a pregnancy of unknown location. Incidence of PUL is about 8 to 10%, which depends upon the expertise of the examiners, USG, and gestational age. Serial HCG along with TVS is now the modality of choice to diagnose PUL. Now here it's written the serial HCG and TVS, but I think the higher this also is important, MRI. In TAS, IUSAC suggestive of normal pregnancy is seen at beta HCG levels of 6,500 international unit, and TVS can pick up more than 1,500 international unit.
Right. Next, Rakesh. So we will see whether the PUL, whether it is intrauterine pregnancy, failing pregnancy, or ectopic pregnancy. That we have to rule out depending upon the beta HCG and the sonography. Next. So expected management, when beta HCG is less than 1500 milli international unit, patient is willing for follow-up, no pain is there, low declining HCG on follow-up done twice weekly. So transvaginal sonography showing ectopic pregnancy, but no free fluid is there. Transvaginal sonography done weekly once, and the success rate of this expectant management is 57 to 100%. Means don't rush for the any surgery if only if there is a ectopic pregnancy. Just observe whether the beta HCG is rising or not, and then take a call. Next. Rakesh? So there is a discriminatory zone of 1000 to 1500 milli international unit per ml. That is if 1500 HCG is there, 80% of the cases, the gestational sac will be seen. And 2000, 91%. And 3500, 99% of the cases, the gestational sac will be visualized. Next. Rakesh? So this is the case 2. Manisha? Manisha Jagpal?
Yes, madam.
Manisha, are you there?
Yeah.
You can take this.
Okay. So case 2 is Mrs. V, age 26 years, married since 2 months, history of 40 days amenorrhea for confirmation of pregnancy. So the patient general condition is fair, BP is 130/70, no significant medical or surgical history is there. On examination, her abdomen is soft and her UPT was positive. So the patient was advised folic acid and review after 1 week for the USG. And beta HCG was 1286.
Next slide.
Follow-up USG was done and repeat USG after 48 hours was 2189. Again, repeat injection methotrexate. And the follow-up again was done and the beta HCG was reducing.
So this is unruptured ectopic and the medical management has been tried. So what are the indications for the medical management of the ectopic pregnancy?
In medical
okay.
Yes.
In medical
Gestational-
management, we have to see the gestational sac diameter. Some book says it should be less than 3 centimeters. Some says less than 4 centimeters. First, we have to assess the. We have to see the fetal heart is there or not in before going for medical management.
The Foxy guidelines and
Pardon?
Foxy guidelines and most of the guidelines mention 35 millimeters, less than 35 millimeters.
Right.
And the beta HCG levels by Foxy, they comment is about 5,000 international unit. Less
Ideally,
than
it is
5,000.
3,000.
But we,
but-
yeah,
3,000.
the 3,000 has a good outcome. That is,
Outcome,
everybody
yeah.
knows the levels less, the outcome will be more than 90% if we.
Right.
But till 5,000, it is advocated to give a methotrexate, but the results might be poor. So you have to do a thorough counseling and then take patient into confidence that
And
she may
fetal
require
heartbeat should not be there.
Yeah, should not be.
And there should not be pain also.
Pain.
Next slide. Rakesh. So diagnosis, yes, Manisha.
So beta HCG after 48 hours has to be monitored and then to see whether it is increasing or decreasing and whether the intrauterine sac can be seen. Again, as previously described, that serum progesterone is important to know whether the pregnancy is viable or not, so that we can go ahead with the medical management. And that is important to whether we have to medically manage conservatively or go ahead with the observe the patient and take the decision for the operative before it ruptures. That is important.
Next slide. Rakesh. Rakesh.
Yes, madam, it is there. So we have to again keep monitoring the patient, whether patient is hemodynamically stable. Better it is the patient is admitted so that we can be alert 24/7. In case if she proceeds with the rupture, we can immediately take her for the operative. And counseling about the methotrexate is important. Along with that, we have to again see for the pain and give her the treatment accordingly.
So how to counsel for methotrexate? Anyone? Dr. Kandarian?
We have to give the methotrexate on depending upon the body weight, 1 milligram per kg body weight, or we can give a single dose of 50 milligram square meter body surface area. And we have to assess that case on a day. If we are giving 1 milligram per kg body weight, we have to see on day 1, day 3, day 5, day 7. And alternate day, we have to go for leucovorin 0.1 per kg body weight. That is a methotrexate management. If you are giving a single shot of 50 milligram of body square meter of body, then we have to assess on day 1, day 4, day 7. And we in this case, we have to weekly get the follow-up of beta HCG until it becomes a negative value.
Right.
Any precautions before giving methotrexate?
Can I just add something?
Yes.
Granulocytosis
To,
will get to
to
things.
choose on the dose of single dose or the multiple doses, the beta
Right.
HCG levels are important to know. If they are 3000, it is you can go for a
Next.
single dose. If they are
Right.
more, then it is the longer protocol works better
Next slide.
because then you have to keep doing the beta HCG, and if it is not getting responded, then you may have to convert the at earliest surgical management.
Before that, you should counsel the patient for methotrexate injection. That there is a recurrent ectopic in 18% of the cases. Risk of rupture during ectopic pregnancy treatment management will be there. Vigorous activity is to be avoided. Avoid folic acid basically and give folinic acid instead, and avoid alcohol also, and the narcotic analgesic should not be prescribed in that case. Next slide. Manisha.
Rakesh, can you shift to the next slide? Yes, so here's the protocol that single dose and multi-dose protocols we are going ahead with. So as rightly said, that single dose methotrexate 50 milligram per meter square of the body surface area, and multiple doses we have to see accordingly. Day 1, day 4, day 7, and beta HCG monitoring is continuously to be seen. If it is decreasing, then it's good. If it is not, then again we have to think of what is to be done again. Again, close monitoring of the patient.
Right. At least there should be more than 15% drop on the fourth day of the cycle of the giving this methotrexate dose. Because if it is less than 15%, it has not worked. You can repeat that dose on the fourth day methotrexate dose. And then again see on the seventh day whether the beta acid is in the reducing titer or not. Maximum how many doses can be given?
Only 2 doses can be
There are
given.
2 doses per cycle,
But
but
otherwise, you have
maximum
to
4 can.
convert into surgical management.
Right. It is better to convert it into the surgical management. Next. Next slide.
Next slide.
So the recent advances in the management is of methotrexate is lower threshold. See, Manisha.
Yes, madam. So when the beta HCG levels are around 5,000 to 7,000, then the outcome with the methotrexate will be little guarded, and we have to be very conscious. And in combined therapy, we can use the mifepristone along with the methotrexate, and the predictive markers for the beta HCG. We have to again monitor on the day 4. If it is reducing, then we are in the good position to control with the medical management.
Sometimes local methotrexate can be given in that. Next. Even nowadays, electrodes is also used for this management of the ectopic pregnancy. Practical clinical algorithm, that is if the patient unruptured ectopic, stable patient, beta HCG less than 1500 and falling, expectant management. If the patient is stable, beta HCG less than 5000, single dose methotrexate will work. If it is more between 3000 to 4000, 5000, then 2 doses of methotrexate is to be given. Cardiac activity, high HCG, failed methotrexate, laparoscopy is the gold standard treatment. Next. So surgery. So laparoscopic surgery is preferred nowadays. And yes, Kiran, what you will advise?
Okay, the surgery, the choice is salpingectomy and salpingotomy. Now the choice salpingectomy will be depending on her obstetric history and the cause. If there is an obstetric history where it is the family completed, then you can go for a salpingectomy, and avoiding the ovarian blood flow, hampering the blood flow. Salpingotomy is the option where the patients are infertile and where you need a tubal function to be preserved. But if there is a PID, again, the concern will be more. So that time again salpingectomy need to be done. Like in India, most of the cause is the tuberculosis. So if you know the tubes are the pathology, then it is always better to go for salpingectomy, because even the IVF results are going to be poor in such patients.
Right.
And in salpingotomy, many times the chorionic tissue remains. So you have to, if you are doing salpingotomy, you need to do the serial beta HCGs. And
Right.
till the beta HCGs, you cannot, the follow-up of the patient should be there till the beta HCGs are less than 5 international units per.
Yeah. About the salpingectomy, it is to
You
be.
may have to give a methotrexate with salpingotomy if you find the beta HCGs are raised or
Right.
not up to mark fall down. So then you may have to give a methotrexate.
But there are 20% chances that repeat ectopic might be there in salpingectomy. And about the salpingectomy, the tube is to be cut just near to the mesenterial border, because so as to keep the ovarian blood flow. Otherwise, there will be reduced this eggs will be there. She may go into POR. Next. Next.
Yes, case 3.
Sai, now you will be answering the next question. Sai and Neelam.
Yes, ma'am. Yes.
Yeah.
Yes.
Ruptured ectopic pregnancy. So, how will you manage?
Ma'am, ma'am,
Yeah.
Ma'am, resuscitation of patient, making the patient stable, and if the it is ruptured, so you cannot waste time arranging for blood products at the same time arranging OT. So everything has to be done hand in hand.
Right. So immediate priorities are there, and
to stabilize the patient and.
So emergency, what you will be doing? Only the bedside sonography you will be doing, and no need of beta HCG. You will be having diagnosis immediately after doing the sonography, right?
Yes.
So do not delay the diagnosis if it is unstable.
Yes.
And the ABC management, ABC resuscitation. Neelam, you can tell. You can.
Yes, ma'am. If sonography is not feasible, you can have aspiration through POD. And if blood is there, you can diagnose immediately that she is in ruptured ectopic. And general condition vitals, if not stable, you stable them and immediately take patient after informed consent to the OT.
Right. Next slide. Manisha.
Okay,
so what, how?
With
Yes, you can. Go ahead.
Yeah, with the ruptured ectopic, there is always a massive blood loss, and then we have to think of all these things. So how you can proceed with the transfusion strategies for such patient?
Neelam?
Ma'am, before we have blood products, we can have crystalloids to stable her systolic blood pressure. And we can operate her within that half an hour or 40 minutes, blood will be there.
Right. So what
That
will be
is
the
the
balance
strategy.
ratio? That is?
I don't, yeah, you have given in the slide, it is 1:1:1. But
Right.
I always prefer it's PRBC, preferably, rather than giving FFP.
FFP.
Yeah.
So FFP is needed because in that case.
Not in many cases, ma'am. FFP is not needed.
See, if there is massive transfusion, you have to give it.
Okay, ma'am. Okay.
If the patient is in shock, then we have to give the FFP. Previously, we used to give 1:4, but nowadays it is 1:1:1 combination, which we are giving. The target is hemoglobin more than 7 to 8 gram per percent, and the fibrinogen should be more than 200. So FFP will increase the fibrinogen level also. It will give the proteins also, as well as the clotting factors also. So it is very much needed in the massive blood loss cases. Next, Manisha.
Yes, so for diagnosing the ruptured ectopic, the important thing will be that we have to do the TVS or see the free fluid and the adnexal masses, whatever it is there. And in case of emergencies, we have to be very quick about the decision making and save that golden hour, because the delay will increase the blood loss, and the patient's morbidity and mortality increases. So it is directly proportional as much as you increase the time. So decision making, if USG is not available, then beta HCG, if it is not required, rather it is such a chronic, immediate, acute condition that we need not have to wait for the blood levels and samples. Only doing the USG will suffice for this. So going ahead with the surgery, which would you prefer? Laparotomy, laparoscopy?
If patient is in shock, I always prefer laparotomy. But if
Right.
patient is stable or we can have some window, then better to go for laparoscopy.
Right.
And what about the preserving of the, this is already, we have spoken about the salpingectomy and salpingotomy. And what specific post-operative care you would like to take?
And salpingectomy and salpingotomy will depends upon the patient's stability hemodynamically, her fertility desire or her fertility index, whether she wants more pregnancies or anything, and the condition of the other tubes, the other fallopian tubes. If it is also bad, or then we'll go for the salpingotomy. And if that tube is better and fertility we have to preserve, then go for salpingectomy.
Right. And what is the post-op care you will be taking? Sai?
Ma'am, not to give excessive fluids, rather replace by blood, PCV, FFPs, and tranexamic acid injection pause IV. I will prefer it 8 hourly, and propped up position, O2 if required, if HB is really low, and this monitoring of pulse BP, TPR BP charting. That staff should be doing it 1 hourly at least for first 4 to 5 hours. After that, they can do it 3 hourly.
Yeah, right. Next slide. Next. Manisha, go ahead. Cervical pregnancy.
So cervical diagnosing and proceeding ahead, how will you think of? What will be the symptoms that patient comes with when it is a cervical pregnancy?
It is intermittent pervaginal bleeding. That is the main complaint. It is not continuous. There is less pain. Patient don't have any much abdominal pain actually here, but there is pain at vagina. That is some different symptoms. And history of amenorrhea may not be here in these cases.
But
They thought it is
spotting
a
is
delayed
there.
menses.
Yeah, intermittent
they thought
spotting
it's a
is
delayed
there,
menses.
which is confused about whether there is pregnancy or not, and what's going on like. And diagnosing will be like USG. Clinically, other things won't be there.
This may mimic as a incomplete abortion or RPCOS in cervix, but if you go for dilatation and curettage, there is a profuse bleeding in these cases. So really, cervical ectopic diagnosis is really difficult.
Yes, and explaining the patient. Sometimes patients say, "Madam, ती वरती नाही ढकलता येत का?"
Yeah, yes.
Slide हे कर ना, next slide. येत नाही का? आलं बघ.
Yes.
So these are
findings for the madam.
So these are the sonography sign. That is the empty uterine cavity, hourglass shaped uterus. Kiran, you were telling, no?
Yeah, barrel is also one of the word which is used. And basically the sac is below the internal the os.
Below the internal os,
that
yes.
is there.
And the closed internal os is there. Otherwise, it will be threatened abortion, and the presence of cardiac activity in the cervix. That is the diagnostic. Next. So how will you?
Yeah, so the medical treatment goes is the methotrexate injection, surgical. And this is a here you can give by under the supervision, under sonography guidance or hysteroscopy guided, you can give methotrexate, and even evacuation you can do. But then this will bleed a lot. So many times you need additional procedures of, as mentioned, uterine artery embolization, ligation, or you can do the non-invasive ballooning, the uterine artery ballooning before this, because cervical pregnancies will bleed a lot.
So it's difficult to go for the surgical procedure for the cervical pregnancy because of the threatening of bleeding, excessive bleeding. So better we give the methotrexate and wait and
At
see
certain
whether
during the procedure, we can do the mechanical pressures like police balloon and all that. This can be used so that the mechanical pressure can help, and at times with adding with the methotrexate, because
yes,
many possibility that it can remain the tissue, the prophylaxis tissue may remain. It is difficult to evacuate surgically, so you may have to supplement with the methotrexate. Okay.
so combined method is needed to
So certain time, like the initially discussion, it mentioned that it might be missed as a like incomplete abortion or something in the lower segment, and you've taken a patient, and then you understand this is ectopic. So these are the things we can do on table, that at least mechanical pressure and Foley's this can be done.
yes. Next slide. Okay, so scar ectopic. How will be the patient approaching you with the scar ectopic? Any
Many times this patient doesn't have a bleeding per se. Many times they have a just whitish discharge and pain in the lower abdomen.
pain?
And typical history, they have to have a previous surgery on the uterus.
Yes.
So that is the one history which is always there, that either a hysterectomy, mammectomy, or some uterine surgery is done. So that gives a clue with
Previous
persistent
section.
pain. Yeah, with persistent pain and abnormal discharge and missed period. This can give a clue to the scar ectopic.
Yes. Next slide. Okay, so scar ectopic is one of the most high-risk forms of pregnancy with the massive hemorrhage if we go on, and chances of uterine rupture and placenta accreta if we are not dealing with it early. Then if the pregnancy is reaching to the term or advancing, then placenta accreta is the most common thing that we can see. And the types that we can differentiate between the scar ectopic is like endogenic and exogenic. So how you will describe this detail?
Ma'am, in case of exogenic, by TVS, the sac, there will be very less myometrium anteriorly to the sac. So that would be one diagnostic thing, and it has a high risk of rupture. So, and exogenic can be managed by laparoscopic removal of the scar ectopic by separating the fold. And
So
I have
if
seen
you look for
clinics,
an
so I know.
indentation in the bladder, I think if you do take a half
Yeah,
away
at the site of scar where the pregnancy is implanted, you need to see it very keenly whether it is intending outward or inward.
Outward or inward. Yeah.
Yeah. So if there is no indentation, then you can have a clue that this can be evacuated, and you can just have a look laparoscopically whether I mean, you can evacuate from I mean, as a suction evacuation, but you can simultaneously you can have or laparoscopic guided you can have. I mean,
Yeah,
both
laparoscopic.
can try. Yeah.
So
So every time you need
endogenic,
not rush to do the scar excision and do the metroplasty.
yeah, for endogenic, it is the hysteroscopy which can be done, and for exogenic, it is the if the myometrium between the bladder and the uterus, means the sac, is less than 3 millimeter, it is always go for laparoscopy. And if it is more than 3 millimeter, then you can try for hysteroscopy also. And if the family is complete, if the family is not complete, then you have to go for the laparoscopy and scar repair. Next. So anyone of you tell us the USG findings. Say.
So okay.
Uterine cavity will be empty.
Yes.
Cervical canal will be empty. There will be sac which will be at the level of internal os, and the myometrium, as ma'am you already said, the myometrium between sac and anteriorly will be less than 3 millimeter, and the triangular or deformed gestational sac, I'm just reading it there, and negative sliding sign. Yeah, right. The GSAC won't slide away, so negative sliding sign. Hypervascularity will be seen on color doctor.
Next slide.
Next slide. Okay, so we have already talked about this, that management will be surgical. In case of more towards the uterine side, we can go hysteroscopically, and if it is intending outward, then laparoscopy with the scar repair is the gold standard. Next. Okay, so management of scar ectopic again. Management as such of the ectopic pregnancy. What will be the line of treatment? We have already discussed. We'll just sum up with this.
Ma'am, sorry to interrupt. Can we hurry up a little bit because it's already 8:30 now?
Yes. So if the patient is hemodynamically stable and ruptured, then we have to think of the emergency management also. So if it is ruptured, then emergency management, go for the laparotomy or laparoscopy, and depending upon the gestation, we can think of the mass, how much it is, and excise, and then repair the scar and control the bleeding. So uterine artery ligation, or the depending upon the how much the bleeding is there, we can go ahead with the ligation of the major arteries.
Next. Next slide. So what is the best modern approach? It is early scarectopic, then and the patient is stable, local methotrexate plus or minus systemic methotrexate can be given. If there is viable pregnancy, then local KCL plus methotrexate. If there is high vascularity and high beta HCG, then uterine artery embolization plus suction or hysteroscopy can be done. And if there is a type 2 or thin scar is there, then laparoscopic excision plus repair can be done. Next. Manisha? Yes. Follow-up and the future fertility counseling. Follow-up serial beta HCG till 0 is there.
Till it is less than 10 or less than 5. Yeah, till
Right.
0. DVS
Yes.
monitoring. Watch for
Right.
delayed hemorrhages and retained
Right.
tissues, right?
Right.
And always explain risk that she can have ectopic in future pregnancy. So she has to report early when she misses her periods.
Exactly. And do early TBS
Delay conception
transfusion.
for another year. Yeah.
Right. And consider
And
scarring.
for contraceptive methods, intrauterine devices are not allowed in
Not
these
allowed.
cases.
Yes, right. Next. Might be the last slide. Thank you.
Thank you.
Thank you very
One
much.
thing,
All
one
brilliant.
thing is there that in ectopic, if the patient is negative, then you need to give a anti-D.
Exactly.
Yes,
Yeah,
yes,
we
right.
That's the
forgot
most
that. Yes,
important
yes,
point
yes.
that you have suggested, huh? Yeah. So
Thank
thank
you,
you very
madam.
much, all the panelists.
Thank you, madam.
Thank you,
Thank you
ma'am.
so much.
Thank you very
so
much.
much. That was such an
Ma'am.
informative session. Thank you,
Thank
everyone.
you, Nalini madam, Manisha madam.
Thank you,
Wonderful
Nidhi
panel.
madam, Manisha madam. Thank you, madam.
Thank
Congratulations.
you.
Very nice panel, madam. Very, very
Yes.
insightful perspectives by all our panelists.
All
Dr.
the
Madan,
panelists
you
were
extend a vote of thanks or?
Yes. On behalf of Amogs and Committee of Safe Motherhood, I would like to extend my sincere thanks to all the Amogs office bearers, chief guests, guest of honors, zonal coordinators, all the speakers, and moderators, and a wonderful panelists for making this panel and all the sessions very uh, interactive and interesting. I think Nalini madam was fantastic, along with
Yeah,
Manisha
it
madam.
was.
Neela madam, hi.
Hi, sir. Yes.
Yes, Dr. Sai. Yeah, it was very wonderful, and
Hello,
thank you
sir.
so much. Looking forward to many more sessions in future also, in person also. And requesting all the presidents and secretaries on behalf of me, Dr. Madan and Dr. Prerna, to kindly nominate from your society for upcoming Foxy elections. I think you will be receiving the Foxy link in this week, and we have to do e-nomination.
Yes, sir. Yes.
All the best, Madan.
Yes, thank you. आमच्या
Yeah,
आठवण ठेवा,
yes,
support
sir.
करा.
All the best, all
Yes,
the
Namaste,
best.
yes.
sir. Namaste.
Yes, thank
Definitely,
you.
Thank you.
definitely.
Thank you so much.
Thank you.
Thank you. Thank you
Thank you for
all.
Chalo.
the
Madam, thank
opportunity.
you.
Thank you,
Yes,
everyone.
Vaishali madam is also there. Yes. चाळीसगाव फक्त जॉईन नाही झाले आज. चाळीसगाव, बारामती. छान झाला पॅनल.
Oh, sir. Thank you.
Actually,
Thank
madam, I
you.
tried calling you, but maybe your phone was.
Not there. Not working, it seems. Yeah.
No, it was working. It was forwarding calls.
Okay, is it? I'll see. Thank you. Thank you, Prerna, Madan,
Thank you,
and
madam. Thank you.
Rachna.
Yes, thank you so much.
Uh,
Chalo.
every good thing has to come to a conclusion, and it's customary to extend our vote of gratitude. And we extend our vote of gratitude to all our chief guests, our guest of honor, our tech partner, our panelists, our experts, our moderators, all our speakers, and all our chairpersons, and all delegates who have come in to make this program a huge success. We seek your blessings in all our future endeavors and our Foxy elections. Dr. Madan going for STI committee and myself going for Young Talent Promotion Committee. And we are really looking forward for your blessings. Thank you so much and have a pleasant evening.
Thank you, Corona Remedies, for this academic support. Thank you. Thank you, Rakesh.
Bye-bye.
Yes.
Thank
Bye.
you, sir.
Yes, thank you.
Thank you.
Thank you, ma'am.
Thank you. Thank you, Rakesh.